Well, hello, hello,
Hey.
hello. It's been a couple weeks since we met. You guys are both feeling okay now, so that's good. And we have Renee is now in Arizona. You guys in your daylight savings time. It's like
Trying to figure out what time.
You guys in your daylight savings time. We don't.
That's right. You guys stay still, but you're still affected by us, right?
Yeah, because I am confused half the year.
Oh, seriously. I know. I feel like it almost makes more sense for Arizonans to just give up and just say, okay, we're going to switch to,
We're waiting for the rest of the world or the rest of the country to give up.
I just wish they would pick one. I mean, I'm not even sure like which one is the one that you're supposed to be on, but whichever one, just pick one and stay there is my thought.
I know.
Just pick one.
I mean, wasn't the original concept for agriculture, and before they had lights on the agricultural equipment, and so it's like it doesn't matter anymore.
No,
I mean, I have heard the argument about kids waiting for the school bus and stuff in the dark, but I don't know. I don't think that, relatively speaking, I'm not quite so sure that there's that many kids that like are actually out there. That most kids are car riders. Like when I was a kid, we did walk. I mean, we walked to school.
Yeah,
we lived like maybe 3 blocks away from the school, just in a suburb. And so there was a group of us that walked to school every day. But I just don't know that now that really applies that much anymore. Yeah. I don't think there's very many walkers.
If they're worried about it, then they can just make that the time for the year instead of the daylight saving. Figure it out.
So Nina says every state needs to join Arizona.
I agree. Just pick one and stay there.
Seriously, I think that if you polled people, most people would agree.
Yeah.
But it's kind of like the U.S. still using, we're not going to the metric system, and the whole rest of the world uses the metric system. But then here we are, holdouts.
Well, that's kind of different. I mean, because we are like the most powerful country in the world. So if we want to use our own system, I say go for it, because we are America.
We're America, huh?
We're America.
Well, we need to make sure we at least.
And football is a oblong shaped ball. It is not a soccer ball.
It's not a soccer ball.
The rest of the world says. They call soccer football in the rest of the world, but no, it's not. Football is football, and soccer is soccer.
FUT, but ball. Yeah.
They call it football.
Yeah, I don't know. I mean, where did soccer originate? Do we know?
No.
I would think wherever it originated, they might have a little bit of a say, but that's okay. We do our own thing. I mean, seriously, right?
Because we're America.
We're a nation of rebels. We're a nation of rebels.
We are the rebels. We're Yanks. The whole country was. Now, being a Yank is different from being a Yankee.
Yes.
There's a difference.
Yeah.
Americans are Yanks, but then Yankees are something totally different.
Yeah. Well, we're definitely rebellious, but that's a whole other topic. So But anyways, good. Well, so I'm getting ready next week. I'm not gonna be able to do next week because I'm gonna be on an airplane.
Yay.
Woo-hoo, where are you going?
We're heading to Florida early for Hack Your Health. So Dave and I are flying over on Tuesday, and we're going to be there for 2 weeks. So I'm going to have 1 week in between where I'm going to be, here, but able to do this. But then the following week, we're going to be on the plane flying back. And so, so we're doing, we're going to be in Daytona Beach for most of the time, but then we're going to be over in Tampa for Hack Your Health, and then back to Daytona Beach. Yeah. And so we're planning on going to Disney World, and with no kids, just the two of us.
Oh, that'll be awesome.
So, yeah, it'll be great. And so, I mean, I wouldn't have been able to walk around Disneyland. I've been to Disneyland a lot because I grew up in California. I've been to Disneyland plenty. So, but I know Last time I went, I was really morbidly obese, and man, was I in pain trying to, in every place I could sit down, I was sitting down. So it'll be interesting. I've been to Florida, but only for a cruise. My sister and I went on a cruise quite a few years ago, and it took off at Florida. So really, I haven't really been to Florida.
Yeah.
I don't count when you fly into the airport and then you go to the cruise ship terminal, and that doesn't count.
I'm excited for you.
Yeah. Do you like Florida? Have you been?
Oh, I've never been.
You've never been?
I'm excited for you to experience something that you haven't got to experience the way you are now.
Yeah, exactly. I love it. And that's why we go places with Healing Humanity, but I try to make at least a trip out of it. Just like when we went to Arizona, we were there for 2 weeks.
Right.
It was a 1-day meetup for Healing Humanity, but Dave and I were there in the area for 2 weeks. And I got to go horseback riding, and we did a dune buggy desert tour, sunset tour. And, we did the Grand Canyon and just traveled and explored and everything. And so that was really cool. I had a good time. So let's see. Thomas says, I have to miss this year, but I'm hoping to go next year. Oh, I'm going to meet Lewis. Awesome. He's going to be there. Excellent.
Oh.
Yes. Thomas, we're Americans.
We're Americans. That's right.
Oh, well, thank you.
Super duper.
Super. So it's going to be really cool. And so looking forward to being a kid and going to Disney World. And we're going to go to Epcot Center, and I think their Wild Animal Kingdom, the animal park. Yeah. So, because we love animals, and so that'll be really cool. So we're hoping to hit all 3 of those, but top priority would be Disney World. And I'm looking forward to getting on the rides, and not having to worry about fitting.
I love it.
Because so often, like, I don't know about the Disneyland rides as much, because a lot of those, like, I don't know if they go upside down, but I used to, when I was a kid and a teenager and stuff, I used to like to go to the amusement parks where they have the roller coasters.
Oh, I love roller coasters.
Yeah, they go upside down, so that the thing that they pull down over your head has to be able to lock into place. So for decades, I wasn't able to go onto anything like that because I was too big, and not that I wouldn't even fit in the seat this way, but I was too thick, and there's no way it was going to lock into place in front of me. So so I'm looking forward to going on rides and having fun.
It's a whole new world, Lan.
I know. Absolutely. Very cool. Yeah. And so we're in the process of negotiating on the property that we had put in an offer like a month or so ago. And it was kind of a little bit of a low ball offer, and they didn't even respond. And so, we put in another offer. And so now they've actually countered this offer, or we came up, they countered. And so we're going to see, hopefully with this week, we're going to be hopefully in contract. Hopefully we can come to consensus. Yeah. It's one of those things where it's an estate sale, and there's 4 siblings, and 3 of the siblings are like, we want to get this sold, and we probably could have been in contract a long time ago. And then there's one sibling that's the holdout that, like, I think our realtor told us that we were the first offer that they had that they even countered.
Wow.
Because they would just not even bother countering because but this is the house it's like the Frank Lloyd Wright style house. Like, Frank Lloyd Wright didn't build the house.
Yeah.
But it's built along the style of Frank Lloyd Wright. And there's differences in Frank Lloyd Wright homes, but there are some Frank Lloyd Wright homes that are notorious for having no right angles. This is one of those where there is not a right angle in the house. And so that creates a huge challenge for a lot of people. but we're willing to take it on because the house is amazing. The land is amazing. The view is amazing. And I just think that it's going to be kind of fun to figure out the best way to configure things so that it'll work. And I've been looking up a whole bunch of stuff about Frank Lloyd Wright design for those weird angles. And I think we're going to have to do, my husband and my son-in-law and my daughter loves woodworking too. So maybe I'll learn woodworking, but we're going to have to get all the woodworking equipment and probably do a lot of custom stuff. And even just, you know, like our bed is a king size bed. I don't even know how we're going to fit it because the angles in the room, there's like, it's like a hexagon. It's all the hexagon.
Wow.
Oh, yeah.
Yeah. And there is a Frank Lloyd Wright house that I saw online that it's all hexagon based. And I think that this house might have been patterned after that. So, yeah. So even so when it's all hexagon, so when it's all hexagon based, if you stop, you know, go into a room that it's a hexagon, you've got where it's supposed to be 4 walls. Now you've got 5 walls. So each wall is a little shorter, right? So like, how do you manage to get a king size bed in there?
Difficult to put furniture up against the walls.
It is difficult. Yes.
Yeah.
But we're up for the challenge, and I plan on recording everything that we're doing, and you know, we'll see. It'll be fun. So,
that's
alrighty. Oh! I used to live in one. Oh, you did? Oh, cool. Oh, and thank you so much for sharing the live stream. I appreciate that. Yeah. So, okay. Well, you'll have to give me any tips on how to decorate and navigate in things in a Frank Lloyd. I get lost in this house. Like, seriously, you can get turned around in this house trying to figure it out. So,
wow.
All righty. Well, let's get going. I know we've talked for a few minutes here, but all right. So for anyone who is new, we are going through this textbook. It is called Ketogenic, the Science of Therapeutic Carbohydrate Restriction in Human Health. It is a medical textbook. And unlike a book club where we read ahead, we are just reading as we go and discussing as we go, which is why it takes us so long to get through it. We are on chapter 3, page 138. We're in the endocrine chapter, and we kind of left off at a weird spot, but we're in the section on managing the patient. So keep in mind, since this is a medical textbook, there's going to be sections on how to manage the patient. And they do talk about medication management. It's not all just lifestyle. There are medication management recommendations in here too. So we left off on, so there's this section actually is on pharmacotherapy, which is drugs, all the different drugs. And we're talking about type 2 diabetes. This is that section. So,
there were some really tough words in there.
Tough
drug classes.
So we're going to flip, Renee, about whose turn is it to start reading in this time?
Oh, I have no idea.
All right.
I know I read last time because I was stumbling through all those drug classes.
All right. Well, I guess maybe I'll read and I'll pick up with some of these fancy words, stumble through them. So, okay.
You'll be fine. I mean, if I made it through, I think with your medical knowledge, I think you'll be okay.
I hope so. I tell you, whoever named drugs, I think was on drugs, to be honest.
Oh, they were just messing with people.
Seriously.
That's what they did.
My gosh.
Yeah.
Like, let's see how hard we can make this.
Let's see how few consonants we can use in a word or how few vowels. How many consonants and how few vowels?
You know what's a drug that I've heard mispronounced so many times over my nursing career is metoprolol. I heard that's a blood
metoprolol.
Metoprolol.
Metoprolol. Okay.
It's a blood pressure.
Is it?
Very commonly used blood pressure medication.
Oh, okay.
Yeah. So it's not like it's a rare medication. It's used all the time. And I can't tell you how many times I have heard that, not just patients, but medical staff
I would have flunked pharmacology if we had to have an oral exam and they wanted us to pronounce everything.
Pronounce everything.
I'm sorry. Like, my brain can't even compute some of these words.
Oh my gosh. And who's to say who's really pronouncing it right? Because sometimes even if you pronounce it phonetically, it doesn't mean you got as my husband would say, well, you've got the emphasis at the right place.
You know, emphasis.
Yes, he always says it all depends on where you put the emphasis.
Oh, right.
That's great.
Okay, so we are on number 8. So these are the categories of drugs used in type 2 diabetic patient, the specific medications and their mechanisms, basically how they work. So we're on number 8, which is glucagon-like peptide 1 receptor agonists, which are GLP-1.
Oh yeah,
which we know about those. -RA. So RA stands for receptor agonists. So people talk about GLP-1s. This is what they're talking about. So they include exenatide, and they all end with tide, so that's good. Liraglutide, dulaglutide, semaglutide, and lixisenatide. That I swear
that's
the emphasis was probably not in the right place there. So they increase GLP-1, which leads to a glucose-dependent increase in insulin and decrease in glucagon, which leads to decreased glucose, including postprandial glucose, so basically after you eat. They also delay gastric emptying, which is why some people get gastroparesis because, delayed gastric emptying is gastroparesis, meaning your stomach is not pushing the food through properly. It's slow, which can make you not really nauseated, and some people throw up. So they also delay gastric emptying and enhance satiety, which helps facilitate weight loss. They are more potent than DPP-4 inhibitors. So adverse effects include gastrointestinal side effects such as nausea, vomiting, diarrhea, and pancreatitis. Lovely. They are contraindicated if a patient has a personal or family history of medullary thyroid cancer.
Really?
Yeah.
Because they can cause thyroid cancer.
Yeah. So I know last time, Renee, we were talking about how your where you work, they utilize these to help people transition their diet. And I think I remember asking you, like, how many people that are on them that you see do have some of these side effects?
The most common is nausea. That's what we see mostly is nausea.
Yeah.
I haven't, knock on wood, haven't seen anybody with any serious side effects.
Pancreatitis or
no, but definitely nausea and constipation are like the two big side effects.
Constipation, interesting, because this mentioned diarrhea.
Yeah, and I have idiopathic gastroparesis.
Right.
I got diagnosed in 2010, and people used to be like, "Oh, I wish I could be on your diet," and I'm like, nobody ever wants to be on my diet, and now all these people are on my diet.
Oh my gosh, no! I mean, I dealt with gastroparesis patients when I worked in GI, and
it was awful.
Miserable.
I ended up in the hospital so many times, dehydrated and malnourished, and my vitamin D, all my vitamin levels were 0. Like we drew them, and they were non-existent. I'm surprised I was still alive.
Oh yeah, everything you put in your stomach just sits there, and that it doesn't go through properly. And yeah, so some people are with it get lucky and they're just have mild nausea, but there's other people. Whoa, really severe.
Well, I think it's dose dependent too, because I think for diabetes, the dose was relatively low for these types of drugs. But then when people, some of the celebrities started using them, and it was like this big weight loss hack, and you're kind of using them off label. And that's sort of how it started. And they started getting popular a few years ago because of that. Because the big celebrity secret, for losing weight or whatever. And so then they started increasing that dosage, and it's really not known how long-term effects are with these drugs using them at that increased dose like that.
Yeah, and that happens a lot with different drugs, is that they put it out there for one thing, and then the side effects are what it ends up guiding it into being used for something else. That's how Viagra
Yeah,
started.
that's the one I think of too when I think of that. I used to give it to our babies all the time. I recovered open heart surgeries on babies and pulmonary hypertension.
Yeah. Yeah. So Viagra is an antihypertensive medication, but now it's used for ED because of its effect on the blood vessels.
Because guess what it did? Yeah.
Yeah. Yeah.
Yeah.
Yeah. They found out that, let's use it for this. Metformin is a diabetic medication, but they found out that it can help with nicotine cravings for people who are smokers. And so now you can use metformin if you are wanting to quit smoking. So yeah, there's a whole bunch of tricyclic antidepressants are often used for GI issues and because of their GI side effects.
Wow.
So that's really common for that to happen. Yeah. So not surprised that they take the GLP-1s, and based on the side effects, of, okay, it'll help you lose weight and everything, and they start using it for weight loss. Okay. So number 9 is basal insulins. So this is what people tend to, they're going to inject. So include insulin glargine, insulin detamir, insulin glargine U300, D-gludac U100 and U200, Humulin U500, and NPH. So insulin stimulates glucose to be taken up by muscle, liver, and fat cells, as well as brain tissue. Insulin also inhibits glucagon action, making it anti-catabolic. Supraphysiological doses in those with insulin resistance may increase hunger and contribute to weight gain. Adverse effects include hypoglycemia and lipodystrophy. All right. So, yeah, and insulin, yeah, it is known for making you gain weight. So bolus, okay, so number 10, bolus insulins include, so basal insulin. So let's just, like, for those who don't know anything about insulin, there are insulins that you just take regardless of your eating. And those are the basal insulin. So they're just, you take it once a day and it just keeps your insulin, your blood glucose steady. There's others called bolus, which is what you're supposed to take before you eat.
So my mother ended up at the end. She was on one of each.
A lot of people, that's what they do. They give them a basal insulin just to keep their blood sugar at a certain level, and then because food will bump it up, then they give them the bolus to take before they eat.
Or if you wear a pump, they do it after you eat now, because you can put your card in and the pumps just give you whatever.
And then it gives you based on what you've eaten. Yeah, definitely. So the bolus insulins are regular, Lispro, Aspart, glulicine, Lispro, AABC, and inhaled insulin. Effects are similar to basal insulin, but they are shorter acting and wear off more quickly. Yeah. So, the goal is to not have the big spikes, so they're working at trying to do that with the medicine, which, we know a lot of people like Thomas, who is on here, diabetic, has been able to accomplish it without, just with his changes in his diet. So, okay. So number 11, amylin mimetics include pramlintide, which is less commonly used since it requires multiple daily injections in addition to mealtime insulin. Pramlintide is a synthetic hormone that resembles human amylin, a hormone that is produced by the pancreas and released into the blood after meals, where it helps the body to regulate concentration of blood glucose. Amylin slows the rate at which food, including glucose, is absorbed from the intestine and reduces the production of glucose by the liver by inhibiting the action of glucagon. Adverse effects include nausea, vomiting, and hypoglycemia. I've never heard of that one before.
I haven't either.
Either that or I heard about it in nursing school briefly. But
I mean,
I've
nursing school was like 2.5 decades ago, so maybe I heard about it somewhere along the way.
Right. That's kind of my thought too, is like, well, maybe I heard about it, but I don't recall.
I've never used it.
I've never had, I don't recall having patients that were on it. Yeah. So number 12, other agents with type 2 diabetic indications. Bromocriptine and bile acid sequestrants have also been used with some efficacy in management of type 2 diabetes. Oh, okay. I didn't know that bile acid sequestrants were used. That's interesting.
No, I didn't
It
either.
is interesting.
I'm wondering if that helps with absorption. I don't know.
I have to think about that one.
I'd have to think about the mechanism. It didn't even talk about the mechanism of like why that.
Yeah, they just kind of threw that in there as an afterthought.
Yeah.
I'm going to ask Dr. Google.
Ask Dr. Google why that helps with blood sugar management. So you figure maybe somebody who has a lot of bile their food is passing through too quickly because they end up with diarrhea and they're becoming hypoglycemic maybe? Are you getting it?
Bile acids are metabolic regulators that control glucose metabolism, insulin sensitivity, and energy hemostasis. They act as signaling molecules influencing processes throughout various receptors.
Okay, so they actually have a mechanism on a cellular level.
And dysregulation of the pathways that it involves can cause type 2 diabetes.
Huh.
So because of this close relationship, manipulating bile acid metabolism is being investigated as a potential therapeutic strategy for managing type 2 diabetes. Strategies include using bile acid sequestrants or developing targeted modulators for bile acid receptors.
Okay, that's interesting.
So this is a newer thing, apparently. The way I'm interpreting that, this is a newer,
which is probably why they didn't have a whole lot about it.
Yeah.
Mm-hmm. Yeah. Okay, that's really interesting. That might be worth looking into a little bit more because I know that like people that are eating carnivore or ketogenic diets and stuff, some of them do have issues with their bile production. Yeah.
And the helps to help.
Mm-hmm. Yeah, definitely. Very interesting. Okay, so I'll just read the next section. So the next section is diabetes medications and therapeutic carbohydrate restriction. So diabetes medications work by different mechanisms of action and vary based on their benefits and risks. This is important to consider in light of new evidence for various diabetes agents. A summary of risks to benefits can be found in table 3.5, which is a big table. And I keep forgetting to put the... These big tables, even the pictures, if I bring them up, aren't really very helpful.
Yeah.
But, interesting.
Just know it's not great.
When you compare risks and benefits. So some of them you gain weight, some of them I'm just looking at the weight. Some of them you can lose weight, gain weight, have a neutral effect. Some of them, a lot of them are neutral on hypoglycemia, but some of them can cause mild to severe or moderate to severe hypoglycemia. Yep. Some of them have issues with cardiac.
Yeah, CHF.
More CHF risks with one of the categories, the secretagogues. You have increased risk for CHF. But then when you have this other category, the SGLT2Is, you have a reduced risk of hospitalization from heart failure. So, yeah, very interesting. Okay.
Wow. Yeah,
some of them, even the bones, if you look at the bones, TZD category has a moderate fracture risk. That's kind of scary.
Yeah. One of them's got I was trying to read this sideways. Let's see. Well, I don't know what that is. A canagliflozin warning. What is that? I
Which
wonder.
one are you looking at?
It's the SGLT2Is, and toward the bottom where for bone. It's a
canagliflozin warning. You may have to ask Dr. Google about that one, Renee. Let's see.
there's a couple of them that have that.
What is canagliflozin?
I'll look it up.
And then there's empagliflozin too. I do know what diabetic ketoacidosis is.
Oral prescription medication primarily used to type 2 diabetes, but that's actually the name of the drug.
Oh, that's the name of the drug. Yeah, if you look up at the first. Okay, so what this is saying is that there's
only that medication out of those 4 causes.
The only one where there's a warning about possible problems with bones is that one.
Is that one that's actually in that category?
Yeah. So if you look up at there's 4 different agents. Canagliflozin is one of them. So the warning about the bones only applies to that one.
And then there's the
cardiac but it has a potential cardiac benefit, and the empagliflozin may have a cardiac benefit. So yeah, so that makes sense. So
wow, that's some interesting stuff.
Yeah, so so that's how like the doctors and nurse practitioners and stuff make their decisions about what to prescribe. I mean, they have to look at the patient's medical history and see, like, do they have heart failure? Well, I'm not going to prescribe this particular one because it could make it worse. And
sometimes you are so sick that the risks outweigh the benefits outweigh the
risks.
Even if bad things happen, good things are hopefully going to happen.
Yes. Yeah. And then, when you work in the hospital, especially like with us in critical care and everything, you have to just basically say, what's going to kill them first? We're going to treat that and hope that we can fix the rest that we mess up. If we can keep them alive, then we'll go back and fix the rest. And,
the goal is make it through this, and then we'll work through the next one and the next one.
I'm now imagining dead toes and dead fingertips from epinephrine and from dopamine and all vasopressors. I was a critical care nurse. We cause damage to save people sometimes.
Well, I mean, CPR does that. I mean, you do CPR, you're breaking ribs.
And you're not doing it right if you're not breaking ribs.
You're not doing it right if you're not breaking ribs.
Yep.
So those broken ribs potentially could puncture a lung, puncture your spleen, but you got to pump the heart. So if you're not hearing snap, crackle, and pop when you're doing CPR, you're not doing it right.
Right.
So, yeah. So, but what are you worried about? They're dead otherwise.
Yeah.
So you're hurting, you're breaking their ribs, but you're saving their life. Yeah.
Yep.
Wow.
Yep. So if you ever have to perform CPR on somebody, Carrie.
I have never had to. I had to have classes for it where I worked before, because even though I wasn't a direct care person, I worked in an area where there were medically fragile people. And so they wanted everybody to be trained on CPR. So I had a CPR class every year for years.
Right.
And
so they didn't tell you that you need to be, that you're going to be breaking ribs?
Well, they didn't really just say that, but I mean, they stressed that you had to do it hard. I mean, I guess they would probably make you too cautious. Yeah. And
they in the class,
they taught you what to do, and you actually went through, it was like a whole, I don't know, it seems like the class was kind of long. I mean, like it wasn't days, but I mean, it was like several hours that you were in this class, and you learned all about, you learned about the heart, and then you learned about the techniques, and they changed periodically. It was different, how many pumps you would do versus how many breaths. It changed. They changed the standard at one point. And so they were, but I mean, it's been years since I've had it, but for a long time.
changes depending on whether you're doing it alone or with somebody else too.
Yeah.
Yeah. So, yeah. All right. So, all right. So diabetes medications work by different mechanisms. Okay. I already read that section. Okay. So importantly, blood glucose concentrations typically fall rapidly and substantially when an individual adopts therapeutic carbohydrate restriction. It is therefore essential that medications are adjusted in order to prevent hypoglycemia. The following recommendations are based on combined clinical expertise, clinical trials, and from current published guidelines on therapeutic carbohydrate restriction and medications. When deciding the safety and appropriateness of type 2 diabetes medications with therapeutic carbohydrate restriction, there are 3 key clinical considerations. So number 1, is there a risk of the drug causing hypoglycemia or other adverse events? Number 2 is what is the degree of carbohydrate restriction? And number 3, once carbohydrates are reduced, does the drug continue to provide health benefits? And if so, are the potential benefits greater than or less than the possible risks and side effects? So the preference of the person with diabetes should be taken into account in all decisions on medication changes. Clinicians must support patients by balancing the pros and cons of different approaches. Cost is an issue that may influence medication choice in many healthcare systems. Medication costs are a large burden to individuals and the health system, so that it is advisable before prescribing expensive medications that all other options have been considered. Cardiovascular and renal benefits of certain medications should be taken into consideration and may warrant continued use even when a person has met their A1C target. An easy approach to consider when adjusting medications is using a stoplight approach. So they say figure 315. Let's look and see. Okay, so they literally have a stoplight there.
Oh, that's good. Visual aid.
So caution is the top one with the little explanation point with the triangle sign. It says reducing medication. Patients must be checking blood glucose frequently and have immediate communicating with their clinician. So safe is the green light. So it tells you 3 medications that are safe to, I'm assuming this means to reduce them. Then, oh no, they're safe to stay on it, I guess. And then the yellow light is the ones to reduce. So basal long-acting insulins may need to reduce dose up to 50%, follow blood sugars and adjust as needed, and thiazolidinedione, those. And then the stoplight is sulfonylureas, meglitinides, SGLT2 inhibitors. Bolus mealtime and insulin might need small amounts to correct high blood sugar, and combination insulins like 70/30 switch to basal long-acting and alpha glucosidase inhibitors. So this is just part of the decision making that the doctor will do. It's interesting. I had one of our people in Healing Humanity Life. I remember she was very frustrated because her doctor did not want to work with her on decreasing her diabetic medication. And she was on a carnivore diet and her blood sugar was going down, and she's like, I go to my doctor and my doctor is like, because I'm on a carnivore diet, does not want to work with me on lowering the medication. And the thing that just struck me was, and then maybe there are doctors that are like that. To me, that's so unethical, right?
I think that's
You're putting your patient at risk. The whole do no harm thing when it comes to doctors, that should apply to this situation, right? And I remember telling her, I said, first of all, probably need to find another doctor. But how many times has probably that same doctor been happy to increase the diabetic dosing of medications because someone is on a crap diet and won't stop eating their crap food? I mean, do they ever say, no, sorry, I'm not going to increase your dose? So it's very hypocritical. They're happy to increase the dose when somebody won't stop eating the garbage,
Right.
but they won't decrease the dose when someone is getting their blood sugar under control with their diet.
But since the drug is the protocol, so to speak, then that is the justification.
Yeah. Yeah. And honestly,
Basically.
for people who have been diabetic for decades, sometimes they're not necessarily going to be completely off of their diabetic medication just because they eliminate the carbs. You know, it depends on how much damage has been done to your body. You know, so to
Or
find a
you
doctor,
might not be able to get off right away. I mean, some people have a pretty quick effect, but then other people, it just takes a longer time in order to finally, that they just gradually decrease, and then they may not need the drugs at all, or if they do, it's very little, but it takes time. It just depends. And I think probably, sadly, the older you are, you know, the less likely it is that you're probably going to get off of them completely, but you might. I mean, it is possible.
I don't know, Renee, your company really focuses on blood sugar and diabetes management. What do you have any insights on people getting off of their medication completely and as they're older?
I don't work with diabetes reversal. We don't put diabetes reversal on GLPs, and all my patients are on GLPs. So I don't know exactly how their protocols work. I haven't had a chance to hang out with them to figure out what they do, but I know that each of our patients have a provider that works in our company that monitors the diabetes medication as they're going along and makes sure that they're not bottoming out. Because that's the last thing we want, is to do damage.
Oh yeah. I mean, I always, when I was working, you know, in the hospital and stuff, and even in GI with people, you know, we have to do colon preps. They have to modify their medication. Hypoglycemia was a much bigger concern than a little bit of hyperglycemia. Yeah. All right. So, okay. You want to pick up here, Renee?
Yep, sure. Hopefully my dogs are done barking. That's why I put on full time, because they won't stop barking. My UPS just came to the house. And you get like one visitor a week. It makes everybody go crazy.
They're protecting their domain.
Yep. Okay. Medications that create a risk of hypoglycemia. The risk of hypoglycemia exists with sulfonylureas, meglitinides, and exogenous insulins. When carbohydrate intake is reduced, these medications need to be reduced or stopped, with adjustment being individualized to patient circumstances. The authors recommend at least a 50% reduction in dose of insulin while stopping the sulfonylureas and meglitinides. Further reductions in insulin may be necessary according to the blood glucose response. There may be a period of short-term hyperglycemia while the individual adapts to a lower carbohydrate intake. This is preferable to the risk of hypoglycemia from not reducing dose. I agree.
Yeah.
These patients benefit from reducing hyperinsulinemia. I'm not sure how that word, as this is thought to contribute to many of the metabolic and other abnormalities seen in type 2 diabetes. Hypoglycemia can contribute to increased hunger, making it more difficult to lose weight. Sulfonylureas and meglitinides, the absence of long-term health benefits of these drugs provides reassurance that stopping them will not adversely affect long-term health. So sulfonylureas as second-line drugs may increase the risk of myocardial infarction, all-cause mortality, and severe hypoglycemia, especially in the elderly, compared with remaining on metformin monotherapy. Glucose variability and glucose spikes may be associated with increased cardiovascular risk.
Okay, the beginning of that paragraph about the sulfonylureas and the glutatides, it said the absence of long-term health benefits of these drugs provides reassurance that stopping them will not adversely affect long-term health, meaning that I guess they just know that they don't have long-term health benefits, but it's like we were talking about before, that they just prescribe them because it's better that somebody is on them than not.
Well, they need them for the diabetes, but like some medications like metformin have other things that they do good things for. And so you would not take them off
Yeah.
them, things like cardioprotective. They're, and I mean, they're even showing like microdosing GLP-1s and lower doses of GLP-1s actually have cardiovascular, they help and they protect, and so they're looking at those kind of things. So those drugs don't have any good like that. They need to keep them on them. All they do is one
It's
thing.
like the chart that we were looking at on the next page, where it shows, so like the sulfonylureas which are one of the secretagogues. So that's the second column. So they have moderate to severe risk of hypoglycemia, weight gain, renal hypoglycemia risk. Let's see. They have more CHF risk, so there's actually like no benefit, whereas some of them, there's maybe a possible benefit.
Right.
Yeah.
So there's no benefit.
Just hearing that sentence was just like, wow. Because it just sounded to me like, it's like, maybe you could just pick something else to take. I don't know.
Yeah. Well, I mean, it just goes to show with these drugs, they're not just necessarily like have one thing they affect. They go through your whole system and your whole body, and many of them, they have effects on many parts of your body functioning. So, it could have a benefit or a risk somewhere else in your body that's not even related to why you're taking the drug.
Right.
Well, I guess it's like statins, because like statins mess up, like, sure, they lower your cholesterol, but then they also mess up like your levels of CoQ10, which also interferes with your, hormones and all kinds of other things.
Yeah. And they can increase your type 2 diabetes risk as well. And
we just aren't good at targeted therapy yet. I mean,
right.
We're getting where chemotherapy and some biotherapies are actually targeted and they just do one thing, but that most medications.
And I think a lot of people think that a medication will do just one thing. I mean, I'm not sure exactly when my opinion on that changed. It's not like I made a conscious decision of it, but it's like, it seems like I used to think like, it's sort of like, I guess if you take an aspirin for a headache as an example and the headache goes away, then you just, okay, that's what that's there for. And that's what it does.
I was just going to bring up aspirin as an example. Yeah.
Before you increase your risk of bleeding.
Yes. It has blood thinning properties. And so now it's used more for blood thinning than for headaches.
But I guess the way people are taught is that like this medication does this, and then they cause when I say they, I guess the medical establishment, like when you talk to your doctor, they mention side effects, but it's really not side effects. It's just all of it is an effect of the drug. It's just that some of the effects are good ones and some aren't.
Yeah. Yeah.
Or some we would consider to be good.
And honestly, with side effects that are listed, it's not, I kind of view that a little differently than maybe a health benefit or because not everybody has the side effects.
Right.
So, and I don't know if everybody has the protective, benefit either, but it's complicated. But, like some people can take a drug and they have no side effects at all. And it's like, no problem. And it helps. And other people will take the same drug and they'll have a ton of side effects and it won't even work. It won't even help them. So it's all so individual.
Yeah. I took 3,600 milligrams of gabapentin every single day for 5 years. And most people can barely get above like 300 milligrams. And then it makes them zombies and it like destroys their brains and their function and everything. And I never had to do that to me.
Wow. So so you were taking like, how many times?
Taking a maximum adult dose of gabapentin a day. So I was taking 1,200 milligrams 3 times a day. And I did that for 5 years. And we talked about a doctor not wanting to take me off a medication. I had to threaten my neurologist, like, I'll do it on my own if you're not going to monitor this.
Yeah.
Mm.
Yeah. And we definitely never recommend anybody just quitting off and self-managing their medication. You know, if you're on medication, you got to work with your doctor, or find a doctor that'll work with you. Don't just self-manage, you know.
No, my primary care was like, I'll do it if you won't do it. So, I mean, I wasn't going alone, but I was definitely, you know, like I knew I didn't need it anymore.
Mm-hmm. Wow. Okay. I didn't mean to interrupt that statement.
No, that's
weird. It was just I was like,
really? Perfectly reasonable question. Yeah.
All right. Maybe we can get through to 35222.
Yeah.
Okay. Insulins, unless embarking on an 800 calorie a day, very low caloric and
low carb diet.
I hate that. Low carb diet, similar to the one used in Direct. Practical experience suggests a 50% reduction in total daily insulin at initiation of total carb restriction is appropriate in most cases. In individuals whose hemoglobin A1C is markedly elevated, a smaller reduction, for example, 30%, may be appropriate, with further reductions over time. In individuals on a basal bolus regimen, it is advised to preferentially reduce or stop bolus insulin. As glucose concentration improves, basal insulin can then be reduced. Mixed insulin should be stopped and switched to basal insulin alone, and the daily dose can be reduced by 30 to 50% at the start of total carb restriction. If on a single dose of long-acting insulin with a peak, the preferred timing is to administer it in the morning to coincide with higher insulin concentrations with normal circadian rhythm physiology of daytime feeding and a reduction of circulating insulin from a nighttime fast. Many basal insulins do not have a high peak, especially with reduced doses, allowing them to be administered at any time of the day. Some patients can expect to eliminate the need for insulin completely over the next few days or months as insulin resistance resolves. It should be cautioned that some people diagnosed with type 2 diabetes may in fact have an insulin deficiency form of diabetes, such as latent autoimmune diabetes of adults, LADA, or maturity onset diabetes of youth, MODY. These patients should not have their insulin stopped completely. Endogenous insulin insufficiency is more likely in patients who were not overweight at the time of their diagnosis of diabetes or who required insulin earlier in the course of diagnosis. They are also likely to be more insulin sensitive, requiring smaller insulin doses than typically used in type 2 diabetes. Overreduction in insulin dosage in these patients would lead to significant hyperglycemia, and further dosage reduction should be avoided. It is recommended that expert advice and additional testing, such as C-peptide and GAD antibodies, is sought in cases of doubt. Those are kind of like an adult onset, almost type 1 diabetic, almost, it sounds like. Not quite.
Yeah. It's not like the pancreas isn't working at all, but it sounds like it's not functioning properly.
Right.
You know, it's interesting because with all of this, I mean, it's obviously very complicated to measure, to actually manage these diabetic medications. And which is, again, why it's so important not to just like stop stuff on your own. Right. It just reminds me, so back when I was working in GI and my clinic tried to implement a policy for the GI nurses of like how to get people to modify their medications for their colon preps, because they were going to be doing like a day of clear liquids, and their diet was modified, and so it was important to modify their regimen. And I pushed back like you wouldn't believe. Like I researched, I like the policy was referencing sources. I dug into the sources, and I really pushed back against this policy because of this, because there is no one size fits all. when it comes to, and you got to be, and we weren't diabetic nurses, we were GI nurses.
Mm-hmm.
And so not only do we not manage diabetic medications as GI nurses, but we, they're coming in for a colonoscopy, and these aren't our chronically ill patients. These are just routine colonoscopies, right? I pushed back like crazy, and the policy never went through because I'm like, it is not appropriate to ask the GI nurses to take a formula to tell people what to do and modify their medications without, and they didn't even want us to do it after a full assessment of that patient. And I was like, no, are you kidding? You don't do anything without a full assessment of the patient. So yeah, that's one of the things I'm really glad about, is that I'm glad I pushed back on that, because that policy never went through. I said that needs to go back to their doctor who's prescribing those medications and knows them.
Yeah. Yep. Exactly. Wow.
Yeah.
I don't blame you for speaking up. I'm glad you did. That's an awkward position to put, or not even awkward. Well, it's awkward, but I guess
dangerous.
awkward is the only word I can come up with to put you into that position.
It wasn't safe. Like Renee said, dangerous.
Yep.
Yeah. Well, and the
risky.
thing is,
it's a risky position to put you in. Yeah.
It is risky. And we already had something in writing as far as like what to do with their medications. And I challenged that too, because I'm like, we need to tell them, you need to go back to your prescribing doctor and get the advice from them. And,
100%.
Yeah. And so, because I'd have patients calling all the time going, hey, I got to do this colon prep, and it tells me to do this and that with my medications, but I'm nervous. And I'm like, I would always tell them, you got to go back to your doctor that prescribes them and do what they say.
Yep.
I mean, when we gave them all the prep information, we should have told them, yes, anytime you change your diet, you need to get with your doctor and, for the modification. But yeah, it's definitely complicated and very interesting. All righty. Very good. So we have, we're going to have to come back in 2 weeks because, like I said, next Tuesday, I'm flying to Florida.
She's going to fly.
Yep. Bill, oops, I stopped high blood pressure pills. Yeah. So.
Yeah. I've heard of people like they've stopped medicines and they didn't really realize that they shouldn't. And then like it doesn't matter. Like I'm not saying do it by any means, but I'm just saying, like, I've heard of people like later they stop taking stuff that you really shouldn't stop taking.
Right. And not everybody's going to have a bad outcome from doing that. It's just
and they're like, oops, just like Bill, like, oops, I guess I shouldn't have done that. But if it didn't affect you, then thank your lucky stars. Praise God.
Yeah. Over 69. Beautiful. And I think the takeaway from this is to why you do need to do it is just, to me, this discussion today was a perfect example of, you don't know what you don't know about what else it could impact.
Right. So, what if it's affecting something else, and when you come off of it, like, there's the risk of coming off gabapentin without being weaned off of it is seizures, because it affects the brain. And so you can end up dying from these seizures and stuff. And you can end up in like a tonic-clonic, or status epilepticus, where you can't stop the seizures. So yeah, you're right. You don't know what affects what.
Right. Exactly. And so same with psych meds.
Yep.
Oh yeah.
So yeah. And not everybody can wean off the same. I had a friend that was on benzos, and it took her so long to wean off because she had to almost like microdosing the decrease because of how sensitive she was, and she couldn't wean off like a normal person. So yeah, definitely work with your doctor. Yeah. Cause again, just keep telling yourself, you don't know what you don't know.
Yep.
It's better to be safe than sorry. Let's see. That's wonderful, Bill. Yes, absolutely. That is great blood pressure. Excellent. Good. Awesome. Well, thank you. It was awesome to see you guys, again. And I know we do this based on our schedules. And so sometimes it's like, we're scheduled to go and someone's like, oh my gosh, I'm not feeling good. I'm fighting a cold or whatever, life happens. And so we
Yep, I thought I was catching the old Rona-virus last week. I honestly don't know. I felt terrible by Tuesday evening. And then my wonderful friends told me about nicotine, like using a patch or lozenges or gum, something like that. And so I started using nicotine lozenges and I did not get sick.
Yes.
So,
the COVID virus competes with the nicotinic receptors in your body. And so, yes, a nicotine patch can definitely help. That's why during the pandemic, people who smoked were much less likely to get COVID. And not that smoking is good, never going to recommend smoking,
no.
but pure nicotine itself, it's like our bodies have these receptors.
Yep.
So it can play a role in helping you for sure.
Yeah, so I don't know if that was all in my head or what, but all I know is I didn't get sick.
I'm telling you, it's not in your head because it was
not in
the
your
only
head.
thing that broke my fever when I had COVID. The nicotine was the only thing that got me within like an hour, I felt like a whole new person.
It's a real thing. There were studies that
is amazing. I'm going to have to just read up on that. That is just awesome. I mean, I did not know. I'm so glad y'all told me because, I read up on a lot of different things and watch I watch various alternative health types of things. I'm kind of surprised I never heard that about the nicotine, but.
Well, I mean, it's like there's so much information out there. You can't know everything. I learned it during the pandemic because I watched The High Wire every week, and I learned it through that. Yeah.
My primary care doctor loves nicotine. He thinks it's great for
that's a rabbit hole.
For awareness, for all kinds of stuff.
That's a whole rabbit hole you can go down and the benefits.
Like truly, if anybody ever wants to go down a rabbit hole, go down the rabbit hole of nicotine.
Yeah, the benefits.
I'm going to do that.
Yeah. Yep. So Sharon says it took 6 months to get off a half a milligram of clonazepam. Yeah. Exactly. Never like taking anything. I agree. Yeah. Maybe a good thing to keep in the old arsenal. Exactly.
My entire family has COVID patches or nicotine patches in their medicine cabinets now.
Yeah.
I ordered some nicotine lozenges off of Amazon, just your generic. I think it's like just a generic Amazon brand. I don't know. I just picked something. Yeah, it's the Amazon, just an Amazon brand of nicotine lozenge.
There you go. So Bill says nicotine patch before big crowds. So perfect. Slap on a patch, and then those receptors are taken.
That's a good idea.
Yeah, and the virus has nothing to bind to. Can't get into your cells.
Yeah, next year before I go to the haunted house, I'll make sure that I
It's that haunted house that did it to you. Like we were talking about, probably poor ventilation. Everybody's gunk is hanging out in the air. Imagine that.
All it takes is one person with COVID. I mean, really, it's all it takes.
Yeah.
Yeah.
Awesome. All right, guys. I hope everybody has a wonderful week. Thank you for everybody who joined us. We always appreciate your comments and glad you're here with us science nerds. And we'll see you in a couple weeks. And if for some reason something comes up, like I'm going to still be in Florida 2 weeks from now. So if for some reason I can't, I'll let you know.
Okay.
But my plan is to be able to do it. So
sounds right. You're taking your book to Florida?
I might copy some pages.
Or we just skip it while you're on.
We can just skip the next 2 weeks.
I'm gonna be doing stuff for Healing Humanity anyways.
Okay. Oh.
That day. Yeah. So like 30 minutes.
We'll just keep it up in the air.
Yeah. Keep it in the air. But I'll probably make copies of the pages that we're gonna be covering.
The page.
Page. Yeah, probably page. We did pretty good today, but yeah, so like 30 minutes before we come on, I've just finished up a Zoom call with Healing Humanity Life. And so I'm already on. So I'm planning on
Okay.
doing that while I'm in Florida. So I don't think it's going to be a problem. So
Okay.
I'm glad you reminded me though. Like, I don't want to take this.
Yeah.
That's a heavy book to put in your suitcase and have it count against your weight.
And
Oh
I've
Lord.
taken it before on trips, and I put it in my backpack, and I'm like, oh,
It's like, why did I carry this?
right in the backpack through the airport. Oh my gosh, it's so heavy. So, alrighty. See you guys next time.
Bye, everybody.
Bye, everybody.
I'm gonna just say okay, and alrighty.